All right, to be sensitive of everyone's time, I think we're going to kick everything off. So again, welcome. This is the Aurora Spine and Pain webinar. This webinar is to focus on the insights from the advanced pain practitioners. We have Brittney Misercola, who joins us from Dr. Pankaj practice. She is a thought leader and a visionary in this space and is a fantastic practitioner that really focuses on finding that correct patient for each therapy. We also have Devon Parks, who joins us from Greg Moore's practice, who also has dedicated her career to finding the right therapies for each patient and helping those patients through the treatment process. So thank you guys for joining us. We really appreciate your guys' time, your insights, and your guidance. And I will pass this off to Brittney to get us started.
Awesome. Thanks, Matt. Good evening, everybody. Hope everyone's doing well. Thank you so much for joining us tonight. And I'm super excited, and thanks to Aurora for hosting this. Devon is joining me, a good friend and colleague, and I'm excited to present tonight. As much as we can with this webinar, we would like to make it interactive, and so there will be time for Q&A at the end. So please type in any questions that you may have. And our goal tonight and our hope is that you'll get a familiarity with the platform that Aurora can provide tools in our toolbox for our patients, picking the right patient for the right therapies, and then that you'll go back confidently being able to select the right patient for the right therapy. And we're going to kind of cover the degenerative cascade tonight. We're going to cover spondylolisthesis, and then we're going to focus on SI joint dysfunction tonight. So Tanis, if you don't mind pulling up the PowerPoint for us. Awesome, thank you. So Devon and I both do interventional pain, and I'll let Devon introduce herself a little bit later. As Matt said, I work outside of Austin, Texas in a large interventional pain practice. We have multi-sites and we have 3 ASCs. We have been utilizing this therapy with our patients. And so tonight I'm going to share a little bit about our experience and a little bit about the therapy. Next slide. Tonight, we're going to cover, like we talked about, the degenerative cascade, the prevalence of this condition in our patients, the diagnostic criteria for selecting patients to treat degenerative conditions, post-op management, and then we'll do a case review. And then I'll turn it over to my colleague, Devon, to discuss the prevalence and pathogenesis of SI joint dysfunction, kind of the physical exam, how to select and identify these patients, and then the treatment algorithm for SI joint dysfunction, and then the unique therapies that Aurora can offer us to offer our patients. And we'll end with the Q&A. Next slide. So let's kind of talk about the landscape. So we know, as we all see these patients, that low back pain is one of the most common presenting symptoms that patients seek care for, and probably the most common thing that we see in interventional spine. And it accounts for billions of healthcare dollars per year. You know, it's estimated that there's upwards of 400 million patients worldwide, and epidurals is probably one of the most common things that, we may initially prescribe. We do know that there are risks with associated repeated steroids, and we know that they don't always treat a mechanical etiology. And so our space has kind of changed from just palliative treatment to actually funneling the patient into what I would call destination therapies. And more of a focus. For when I first started from 10 years ago, it was all palliative. And now 10 years later, we've changed, and our focus is actually treating independent pain generators. And when I started 10 years ago, there was not a lot of tools in our toolbox. We had epidurals and RFs and stems, and now we have a plethora of new technology and new things to treat our patients. And, some patients need to go see structural major surgery, and have major surgical interventions. And now there's some interventions that we have and can offer our patients here. So it's kind of been an exciting time to be able to treat some of these mechanical etiologies. And one of the things specifically is the treatment of spondylolisthesis, adding into our armamentarium on top of spinal stenosis. So, the aging population is growing, and this is one of those conditions that's going to happen to every person. I call it, as we become wiser in life, we're all going to succumb to that degenerative cascade. Next slide, please. So when we talk about the degenerative cascade, it all starts with the disc, right? So the disc provides about 80% of the cushion and support for our spine. And we're going to call that the anterior column. You know, that's one of the things that over the last 2 years, we're really starting to dive deep and really understand the spine and the biomechanics and understanding the anterior column versus posterior column. So what happens is that the disc begins to degenerate. I call it as, you know, as we progress, maybe starting in that 40s, 50s, that fourth, fifth decade, and maybe even our 60s, we kind of start to have degeneration of the disc. The disc kind of loses its height, gets a little dry. You may get small tears in the disc. But as that disc doesn't do its job and it degenerates, it can bulge, cause narrowing. And then the load gets transferred to the posterior column, and the posterior column starts to take over. And that's when we start to see some narrowing, and it could be, in the lateral recess, it could be in the neuroforamen, and then it could even be centrally. But then the posterior elements, such as the facets and the ligamentum flavum, may hypertrophy, get bigger. So they try to take over the load where the disc isn't doing its job. And this is the area that we've been really good in pain management at treating for years is, we do MBBs a lot. We do RFs. We've been palliatively treating the pain related to this facet hypertrophy and pain in the facets. Go ahead and go to the next slide, please. But over time, with that narrowing, when that ligamentum flavum hypertrophies, when the facets take over and the disc bulges, then we know we get some stenosis and narrowing. And it can occur in all three levels and areas. So, when I first started learning really about spine, when I thought of spinal stenosis, I typically thought of central canal stenosis. But over time, I really started to realize and understand that stenosis can occur in all three zones, right? It can occur in the central, the lateral, and the neuroforamen. The more lateral and neuroforaminal we get, then we typically see more of a radicular pattern, or it can maybe be dermatomal and we can kind of map it. But as it goes more centrally, that's when we might see more of the symptoms of like neurogenic intermittent claudication, and it may be more history driven or more diffuse and harder to actually dermatomally map. Next slide. So as this process occurs and, these later stages of the degenerative cascade occurs, then kind of a remodeling stage tries to happen. So the spine tries to kind of stabilize itself, and that's where you get kind of some disc osteophytes and maybe some bone spurring, and then maybe a little shift or a listhesis. And this basically happens because there's capsular tension and there's some instability that can occur. There's obviously stages of listhesis, and most of the patients that we tend to treat are in that grade 1, maybe up to grade 2. Anytime they're over a grade 2, most of us in recommendation is to certainly consult surgical colleagues, especially if there's a translational motion of at least 3 or 4 millimeters. So that's typically what I'm looking for when I'm doing my flexion extensions, and I look for some gross instability or macro instability is anybody that's got greater than a grade 1 and they have greater than 3 millimeters of translation. I'm always consulting my surgical colleagues on those patients. Next slide. So when we think of presentations of anterior versus posterior column pain, oftentimes patient can present multifactorial, and it may not be immediately evident. They may have multi-issues. They may have pain with anterior movements, forward flexions, such as tying their shoes, reaching forward to pick something up. I tend to think of those patients with sitting pain. They have a lot of what we used to consider discogenic, or maybe they have discovertebrogenic pain as well, where they've had some changes in the end plate because of that disc disruption there and those end plate changes. And those are patients that we want to look for the disc height. It has that foraminal cave where the nerve roots come out, narrowed because the disc has degenerated. And so those patients typically have pain when they bend forward. Posterior elements usually present patients, and posterior column pain is typically those patients that we would call facetogenic pain, right? Pain with lifting, extension, twisting, lateral movements. And then we've got this kind of middle column that's kind of in between, and that's where those neural elements can kind of cause some compression around them or stenosis. Next slide. Physical exam is really, really important for us and, can't be understated. It can really drive us to kind of lead us to what, how that patient may present and what the pathology may be before we actually look at imaging and see what's really, does that imaging match what's going on with the patient? When we think also anterior versus posterior column, sometimes there can be in the posterior column, we kind of also evaluate for SI joint pathology. I find that oftentimes patients that have L5-S1 disc pathology and maybe painful radiculopathy, sometimes it's difficult to determine, is it truly in that lumbosacral region? Is it that L5-S1 or is it a sacral condition? So that's where, really diving into your physical exam can kind of help lead you. And oftentimes they'll overlap too. And the same thing I find with facetogenic components. Oftentimes, they may have an L5-S1, facet problem and facet arthropathy, and they may have sacral arthritis. So those areas, really diving into our physical exam can really help us with that, and evaluate for any neurological compromise that may lead us to send them to the surgeon. Next slide. When it comes to diving out neurogenic claudication, I really feel like history is the key to this. Sometimes it's really difficult to evaluate that other than looking at a patient that may be coming in with a walker, maybe kind of in a slight forward lean, but really asking the patient those questions that may be, intuitive to them. They may not present with the information of, yes, I can't stand at the kitchen and cook for more than 5 minutes. I have to sit down or I have to use the shopping cart. But I really find that patients that have diffuse back pain that kind of radiates around to the hips, we really have to dive out. Is this radiculopathy? Is there a facet component? Sometimes facets can cause radiating pain. But the biggest key that I find helpful in my practice is I'll ask the person sometimes to stand up, look in do they immediately try to sit back down again? Are they leaning on the table? Are they not standing up straight? And I'll ask them leading things like, how about brushing your teeth? Tell me about that. And they'll say, well, I can't brush my teeth for any length of time. Or I'll say, what about walking through the grocery store? And they'll be like, oh, I have to use the shopping cart. So sometimes, because to them, that's just normal behavior, they don't know that maybe that's, pathologic for them. So I kind of will ask them those kinds of questions to dive out. One of the other things that I found over time is patients, I ask them how their sleeping is. Do they have to sleep? If they say, oh, I have to sleep in a recliner, because laying flat oftentimes is the same as standing, and that puts them in that flexed position and can cause that compression around the neural elements. And that they'll say they sleep in a like a C position on the side, they have to use pillows or sleep in a recliner. Those are all key indicators that we may have some neurogenic intermittent claudication going on. Next slide. So when it comes, it's always great to do a reminder and a review on normal MRIs before we identify and evaluate for pathology. And when we're looking at these MRIs, we want to see nice fluid-filled discs, no significant herniations. We've got no compression on the spinal cord. There, when we're looking, all of those vertebrae are kind of lining up front and back. So it doesn't, appear to be any offset of the vertebrae, no herniated disc. Once that signal loss happens, we're concerned for, disc degeneration and disc height loss. And we'll show some pictures of that in a minute. Some other things is looking at the actual facets. If there's fluid in the facets, that's a sign of microinstability. So that's something else to be thinking about, that if you do see fluid in the facets, they may not have an actual translation, but that is a sign that that motion segment does have some stress on it and may need some stabilization. Next slide. And there you can see there the progression of kind of the degenerative disc disease and some bulging. You see you've got normal discs up at the top, and as we go down, the disc can be graded, one and almost autofused all the way there at the end. So that's typically what I'll do, is kind of look at the disc height, look at the amount of fluid in there. Is there a herniation? Is there a bulge? all in my evaluation for these patients. If I've got somebody with a lateral disc protrusion or herniation, compressing the lateral recesses, I am sending those patients to surgery to evaluate if it's a lateral disc herniation or protrusion. Next slide. So if it's a patient that has disc bulging, fluid in the facets, you can see it L4-5, ligamentum flavum, thickening. Those are all signs, obviously, of some spinal stenosis, fluid in the facets. Those are patients that have microinstability that may need some security at that segment. Those are all signs that I'm looking at for potential candidates for this. Again, if it's a lateral disc protrusion or lateral disc herniation, I'm sending those patients for evaluation. Next slide. Next important thing in the workup is looking at our flexion extension. It's really important to get those dynamic x-rays. And a lot of times when patients come to us, they just have maybe, two views or maybe an L5S1 eye spot. But really, those flexion extension x-rays are super important to look for any kind of translation or shift there. You can see on the very far left on picture A, we see a little bit of a listhesis there, and you can see kind of that haziness around the end plates, pretty much bone on bone. There's not a lot of disc height there, and then you can see that on B too from that view as well. When we go into dynamics, when the patient goes into extension, when you kind of see that alligator sign, that greater than less than, it shows that there's a little bit of angular instability. And when the patient goes into extension, it's actually coming down on that neuroforamen and closing down that neuroforaminal opening. That is a sign of needing some security and stability there. And certainly with that listhesis, if it's translating more than 3 millimeters, those patients should probably be seen elsewhere. But if it's less than 3, grade 1, and they're having all of these signs, these are patients that I'm looking at for this particular fusion device. Next slide. So, we kind of alluded to this in the beginning where, pain medicine, we used to pretty much be just palliative and treating symptomatology, but we've kind of moved more to an interventional and mechanical treatment. And I would highly encourage it much earlier on. So if we've got a patient that has failed conservative therapies, have had epidurals, maybe had RFs, and they didn't really have long-term or significant relief for any length of time, then I'm immediately moving them earlier to look to, is there a mechanical problem here? If they've got any of those signs we've already talked about, they've got a grade 1 with any listhesis and DBD, that motion segment is probably needing some security or some increased height and stability there. And those are the patients that I'm identifying in my practice. If they have a gross instability of greater than 3 millimeters of translation or grade 2 greater, then I'm having them evaluate with my surgical colleague first to see what's needed. And those are the patients that I'm funneling straight in. Not doing repeated epidurals that maybe only last a week or two. And we know that a lot of the LCDs out there aren't even allowing repeated epidurals. So it affords patients the opportunity to actually look at, can we treat the etiology and not just the symptomatology? Next slide. So go ahead and go to the next slide. So let's talk about the Aurora platform for these patients. So we've identified a patient that has degenerative disc and spondylolisthesis that's not translating more than 3 millimeters. That's our patient, right? They have symptoms of, back pain, leg pain, radiculopathy, maybe neurogenic intermittent claudication. That's the patient that I'm offering this for. One level. We can do, usually I'll treat the worst level and where the listhesis is. Most commonly it's L4-5, oftentimes L5S1, which is really unique. And this is the only thing, This particular product has a specially designed implant for L5-S1. We're going to talk a little bit more about that in our case study. But the ZIP product is a interspinous posterior non-pedicle fixation device. It is titanium alloy, and it is specifically designed for treatment of the lumbar spine, and then a specific designed one for L5-S1. And it is indicated for degenerative disc disease and spondylolisthesis, and thus also spinal stenosis. And it is a interspinous fusion device, meaning that it also has bone grafting material in it as well. Next slide. So the landscape of symptoms and indications. So the indications for this, we already talked about, how does this patient present? They could present with back pain and leg pain. They can present with neurogenic intermittent claudication. That is indicated for patients with spondylolisthesis and DDD, and then neurogenic intermittent claudication. Next slide. So medical necessity and documentation is paramount for any therapy that we offer our patients, right? And so documenting failed conservative treatments, at least 6 months. Oftentimes these patients have had much more than that. Previous interventional treatments of, epidurals treated for, ordered for painful radiculopathies, RFs for facetogenic components. They may have undergone other procedures for the anterior column, such as BVNA. So there may be other treatments that these patients have had. But when we have them come back and they have still a little listhesis, DDD, or symptomatic, then consider, stabilizing that segment. And so I usually will document scheduling that patient for the level for posterior arthrodesis at that level. It's really important to document your functional assessments, your response to treatments. I usually will put in an oswestry or something like that, and indicate that you are putting this posterior arthrodesis in for the spondylolisthesis and the DDD. Devon, do you guys document anything else, or is there anything else that you highlight as well?
That's a really good, grouping of what you need to have documented. We have a couple of insurances up in the Northwest that are really specific as far as when the PT was completed. So they have to have at least 3 visits within the last 6 months for a few of our insurances. So we really document well when the PT was completed. We did learn through our experience with working with ZIP is that, like Brittney was saying, when you say in your notes, schedule patient for posterior arthrodesis, it's really beneficial to word it that way and not put in the device name, because the device name can start throwing flags to get denials from the insurance company.
Thanks, Devon. Next slide, please. So I'm gonna take a little moment here, and I'll let Devon and I kind of bounce back and forth of talk tracks to our patients. How do we talk to the patient about this? How do we tell them, what does this device do? What can they expect? We know that that's one of the most pivotal roles besides patient selection that APPs play in a practice. Besides identifying patients and candidates for therapies, we really play a vital role in patient expectation setting and education, right? So when we're talking to the patient about this particular therapy, I think it's really important to let them know that it is a fusion device, that it does have bone grafting material. It does take time to fuse over time, but it should provide immediate stabilization of that segment and kind of some a little bit of height restoration and opening of that neuroforaminal cave. And so I like to talk to my patients about that. And you can see on that top x-ray how, when I was talking about that alligator sign, how when you kind of have that greater than sign. And as you can see below, once the fusion device has put in there, that is leveled out, right? So it has corrected that angular instability, and you've got nice opening there. So I like to tell patients about that. I do tell them that it is minimally invasive. It is outpatient. It is done typically in In our setting, it's in our ambulatory center. Dr. Mehta does take some of these patients. Some of them do go to, we do have a hospital that he has privileges at that he will do it there as well. But most of these patients can be done outpatient from our ASC. What I do talk to them about how it decompresses around the nerve roots, how it stabilizes the spinal segment and opens up that space. I kind of talk about it like the ceiling kind of being raised and the walls being pushed out, and how it will actually keep that segment from shifting. We talk about the post-operative expectations, that it's not uncommon to have some discomfort for the first week or two, that about the dressing, the post-op management. Usually bleeding is minimal, but they can have a little oozing for the first couple of days. Our patients usually go home with a sterile dressing and kind of a pressure dressing around it to kind of stabilize and remind them. Oftentimes we'll put our patient in either a binder or a back brace, more or less to kind of remind them, give them some security, remind them not to start doing a bunch of bending, lifting, and twisting and kind of heavy work there. And that usually when we see them at 1 week, 2 weeks, they're starting to feel better, but it's not uncommon. We do give our patients some post-op medications for the first week or so, ice, and kind of slowly manage them and then progress them on their activities. This is obviously done under general, so any of the required clearances for other like implantable devices that you guys do would be required. That's usually site specific, whether they need MRSA screenings or COVID screenings or any of that. That's independent of the site of service, but certainly blood thinner clearances, cardiac clearances, pre-op lab work is all indicated for these patients. And others might be institutionally required. We pretty much do the regular panels and coags for our patients, and then of course require any cardiac clearances for anesthesia. As far as DEXA scan, highly recommended in high-risk patients or patients that have had previous like fragility fracture, maybe, wrist fracture from a minor fall, long-term gabinoids, long-term Prilosec, GERD medicines can cause that, or anybody postmenopausal that you're just concerned about, you can get one. It is not mandatory and required for every patient. But if they're high risk or you think they have significant osteoporosis or osteopenia, it's recommended. And then risk benefit discussion with not only the patient, but your physician, whether to proceed or not. Certainly evaluation of any previous spine surgery or alterations to the native spine at the implant level is really important, such as, had they already had a laminectomy, discectomy, or some other kind of spine procedure or adjacent segment. Devin, would you like to add, and do you guys do anything different in your practice?
A lot of it's very similar for us too. We do all of our cases under MAC, so we actually do not do general for these. They take about an hour or so, so we're pretty efficient in getting them in and out and do pretty well with that. We haven't had too many issues with it. Patients do well and they wake up and they are ready to go home pretty quick. We do the back braces also. So for stability, we encourage our patients to walk when they can, but using the back brace, and to make sure it's an even flat ground, no potholes, no raised surfaces, because what we don't want to have happen is they step and that shifts or shears, and then we lose that stability back there. We also do check to see if our patients are smokers. We will not do this for a patient that is smoking currently, because it is a fusion. We want to make sure that that bone back there has the chance to integrate and to solidify. We also do check the DEXA scan for our high-risk patients. If it's negative 2.5 or higher, we will send them for endocrinology or to work with their primary care on getting that bone health back up. We do sometimes at least check with some of our neurosurgeons to make sure that they don't feel like a larger surgery is needed. So we have a really good relationship with a few here locally. And so we'll work back and forth. They will send us patients that they don't feel like a larger surgery would be great for, so that we can do some of these smaller procedures. Maybe they're not a great candidate for general anesthesia, but if we can do MAC, maybe we can get them done and get them some pain relief. We also do pain medication for the first kind of 3 to 5 days. That tends to be the most painful time, it seems like. We have some patients though that have messaged me the night of their surgery saying, my leg pain's gone. My back hurts because you cut me open, but my leg pain is completely gone almost immediately. So the results are pretty quick on this, even though it is a fusion. We do counsel patients though that it is a fusion, so up to 3 months sometimes to see complete results.
Yeah, good points. And you're so right. Oftentimes these patients do get pretty significant quick resolution of that leg pain, but the back pain may take a little bit longer. Next slide. So I think we kind of touched on some of this. Post-operative care, minimal bleeding and bruising is normal. These patients can have some of that. Every doctor is going to do their closure different, whether it's staples or sutures. For us, the staples come out, after 2 weeks, they come for a wound check. Most common is just keep it clean and dry, right? There are those 7-day antibiotic dressings that can be used. The most important thing is no submersion of that surgical site, just general surgical site care. Obviously teaching them, signs and symptoms of infection or bleeding to report that, but we're keeping a pretty close eye on them. And we tell them not to even touch the site or mess with the site for the first 72 hours to a week, and then we see them. And then we tell them no more lifting than 15 pounds in the first month. So our patients, we do is the same that Devon said. We are encouraging our patients, get up, walk, but just don't do a bunch of lifting and lifting heavy things and trying to overdo it. Anything else that you do, Devon, there?
The only other thing that I would add is we do recommend our patients stay off of NSAIDs for at least 6 to 8 weeks. So we know that NSAID use can potentially cause that fusion to not solidify back there as well. And so we do counsel our patients to avoid it if they can. So Tylenol up to 3,000 milligrams a day for post-operative pain, and that short course of pain medication.
Wonderful. Next slide, please. So I'm going to talk about one of our cases that we had for specifically L5S1. They have a unique design for this. This is a 53-year-old male. So I'm in an area where I have veterans. I'm outside the largest military installation in the world. And so we have a lot of veterans. And these patients, their degenerative cascade is more traumatic, right? So it's not necessarily just age. So these patients have advanced DDD, advanced arthropathies, and all much younger just because of the wear and tear from military. So this is a 53-year-old that came to us, veteran, had also been involved in an IED explosion. Only past surgical history was his left knee scope. Fairly healthy because he's 53, anxiety, a little bit of non-alcoholic fatty liver disease, but no significant cardiac or, anesthesia risk that I was really seriously concerned about with this patient. He had been on anti-inflammatories, muscle relaxers, the same. He had a neurosurgical consult years ago, but he was so young at that time. They're like, hey, we want to, continue to do all conservative measures. So fast forward a little bit further, a year or two, come see us. He had presented with low back pain, radiating to the right hip and the foot. He did have facet loading. He had anterior flexion pain. He did have L5S1 paresthesia and radiculopathy. No red flag symptoms, no neurologic deficits. Did have some neurogenic intermittent claudication symptoms. His pain scores 8 on 10 for his back, and leg pain 5 on 10. His Oswestry disability index was in the 30s, 30%. Patient had after conservative therapies of physical therapy and all, he did undergo a round of epidurals. He did undergo MBB and RFA, all provided him short-term relief. So we had imaging. L1 to L3 were unremarkable. L3 and L4, 5 DDD, disc bulging. Let's see the corner here so I can read my MRI. L3, L4, disc bulging, facet degeneration, and mild stenosis. L5S1, he had a central disc bulge, disc height loss, and some osteophyte formation. So he's already starting to try to stabilize that segment because of the DDD. You could see that he was going way past in that degenerative cascade there. And he had a grade 1 listhesis, but no abnormal translation. Next slide. With that vacuum disc phenomenon, bad DDD, grade 1, spoke to their patient about stabilizing that segment. So at 6 weeks post-op, his back pain was a 1, his leg pain was about a 1 to 2, but he had multi-level as well. So he had, a couple levels of problems there. His oswestry was a 32%, and by 3 months, his back pain, leg pain was from an 8 down to a 1 to a 2, and his oswestry had improved to 17%. So he had a clinically significant improvement in his functional abilities. He had greater than 80-90% improvement in back pain and leg pain, and his PGIC is considered the patient global impression of change. So that is a national Likert scale that says how effective or impactful does the patient believe this procedure was for him. And 1 means not very impactful or made no significant change whatsoever. And the top scale is 7, meaning a significant improvement in their quality of life. And this patient already at 3 months had rated this procedure for him as a 7, so making a significant impact in his life, and his functional improvement showed it. So anything greater than 11 change is clinically significant. And this was just at 3 months. And so we follow our patients at 3 months, 6 months, and 1 year. And just like Devon said, I tell the patient that it can take anywhere from 3 months to 6 months to actually have that fusion occur. Things that can kind of slow that down can be smoking, taking a bunch of anti-inflammatories after. So we do those same kind of things, but I expect the patient to get some resolution of their pain by 3 months. And this patient certainly did. So this is a great therapy now that we've been able to incorporate for our patients at L5S1 that we've not been able to treat before. Next slide. So if you have any questions about this segment, if you would put them in the chat, and then I'm going to pass it on to Devon to talk about SI joint. And then we will come back through and answer your questions that you might have.
Hi, everyone. Thanks, Brittney. Great job. I always learn so much when I listen to you talk. It's always a pleasure. I'm Devon Parks. I've been with Dr. Gregory Moore for 14 years now. I'm involved in all aspects of care of our patients, integration into ordering the procedures, seeing them as new patients, and all the follow-ups. We see a lot of SI joint dysfunction. It's very common. There was definitely a lot of overlap between back pain, like Brittney was talking about with L5S1 and the SI joint. So there's definitely things to rule out and rule in when you're looking at this. Let's go to the next slide. So what causes SI joint dysfunction? It's under-recognized. We know that there's a lot of people that have this. It's somewhere between 14 to 22% of the population with back pain have some sort of SI joint dysfunction. It's a common source for low back pain, especially in previous lumbar fusions. With lumbar fusions, we know that the stress and the rotation, the torque, all those forces get displaced to the level above and the level below the fusion. So if you have an L5S1 fusion, there's no disc space that's underneath it, but there is the SI joint. And so once L5S1 is fused, you do see that increase in degenerative changes at the SI joint occurs. You can have arthritic SI joint changes. You can also have disruption of that joint, and that can be from a fall, from an injury. When we have pregnant women that have relaxin that's released to help release those tendons and the ligaments for having a child, that then becomes very much loose through the SI joint. SI joint dysfunction is very common in patients who are both pregnant and postpartum. The pelvic girdle gets disrupted with the birth process. And you can also have SI joint pain even from having the bone graft harvest done from a fusion. Next slide. So how do we diagnose this? Next slide. So it's definitely a challenge. There's a lot of overlap. So that L5-S1 disc space is very close to the SI joint. The L5-S1 facet is also very close to the top of that PSIS. And so there's a lot of pain that we have to go through in that area to make sure we know truly what it is. The referral patterns can also be very similar. With the SI joint, you can actually have a pseudo-radicular symptom that happens where you can get pain that radiates down into the lower extremities. Majority of the time, I would say it does not go past the knee, but you can have patients that actually have radicular symptoms down into the leg and even into the calf sometimes. Imaging studies for this is fairly inconclusive. You may see some arthritic change, which can help. Really with more of the images though, you're looking to rule out anything else so that there isn't anything else in the pelvis that could be causing this pain. You're looking at L5-S1 to make sure that there isn't anything there that could be causing the pain. And the imaging is just not always all that helpful. Next slide. So it's always important with anything that we do to actually get a good history and physical from patients. Asking them, when did this start? What happened? Why was it? Was it a fall? Was there a car accident? Was it a lifting and twisting situation? Do you have a previous fusion? Have you had pregnancies? Have you had multiple pregnancies? All of those things increase that potential risk for having SI joint dysfunction. When you see patients with SI joint dysfunction, they will complain of lower back pain. They will sometimes get some tingling, some numbness, some weakness into a lower extremity, either both sides, unilaterally or bilaterally, depending on which side they're having pain on. They'll have pain into the buttocks. They can have pain that wraps around the pelvic girdle and into the hip. They can sometimes feel that that leg is unstable and that it wants to give out on them. It can really disrupt sleep. So when you're laying, especially on your side, that's going to put compression onto that SI joint and that can irritate that joint. Laying flat can also irritate it because if your pelvis is off and it's shifting, then you're actually putting pressure right on that PSIS. You can also see that pain would increase with sitting. So this is another one with a lot of our other conditions within the back that maybe they get worse when they sit. And then they get a lot of pain with going from a sitting to standing position. And I think that there's probably twofold with that, is that SI joint does help balance out that motion of standing forward. And also if they have a weak core structure, that's going to let that SI joint be more unstable through that area and cause more pain. Next slide. So what does it hurt when you're going up and down stairs? So if your pelvis is shifting, that's going to cause irritation in that joint. That transitional movement from going from a sitting to a standing position, or going from a sitting or standing to a sitting position. When you're trying to roll over in bed, most people tend to twist with their hips first, getting in and out of bed. So again, that transition. If you sit on the affected side, and so you'll see a lot of patients that when you talk to them, they may be sitting to one side or the other, or they keep switching back and forth. And then they can also have an increase in pain if they're standing for too long or sitting for too long. What helps is that they tend, if they're standing, they'll shift to one side to relieve the pressure from that joint. They'll try lying on that unaffected side. And then an SI joint or a manual stabilization can sometimes help with that pain too. Next slide. So what does the referral pattern look like? And so looking at this diagram, we're looking at some primary and then secondary potential referral profiles. So you can see that PSIS, that main spot of pain, is very close to that L5-S1. It is slightly below, and then pain coming down into the buttocks. You can get the pain that wraps through and into the hip. And then you can also get pain that's coming down into the legs in somewhat an L4-5 distribution. Next slide. This is another documentation and picture showing those different referral patterns. And so the difference with the disc is it tends to be a little bit higher, tends to be more straight down the leg. With the facets, maybe a little bit more through the buttocks and slightly more lateral. SI joint is definitely coming through the buttocks itself and maybe down into the posterior thigh, and then also wrapping around into that front iliac crest. Next slide. So what do you need to rule out? So there's a lot of things with the SI joint that you have to rule out. Sometimes it's a diagnosis of exclusion because you have ruled everything else out. So you want to make sure that there's no signs of avascular necrosis, severe hip osteoarthritis, a labral tear, damage to the chondrule within the hip, the femoral acetabular impingement syndrome, piriformis syndrome, and a gluteal muscle tear. And so it's really coming down to your examination and making sure you're doing a good physical exam to look for these findings. You want to be able to inspect that area. I always have my patients say, can you put a finger to where your pain is at? And a lot of times they'll point right at that top of the PSIS, and that helps me clue in that we're looking at SI joint potentially. They'll have tenderness when you push over there. The range of motion of the hip is important to check. I watch them walk to see if there's any sort of shift in that pelvis. And then also doing a Faber and Fadir test to make sure you're checking piriformis and SI joint both. Next slide. So with looking at the lumbar spine, what are we looking at? We're looking at the same things that Brittney talked about earlier. We're looking at stenosis, a herniated disc damage, and annular tear if there's instability or if there's facets. Again, doing the physical exam, having them bend forward, bend backwards, looking at their x-rays, looking at an MRI to see if there's anything that's going on, doing a thorough muscular and neurologic test to make sure that there isn't something that's really cluing you in that it's lumbar versus SI joint. Next slide. So how do we test the SI joint? There's really kind of a gold standard for this, which is the nice thing. So number one is the Fortin finger test. Point a finger where it hurts. Most patients are able to localize an area of pain. We do have complicated patients that have pain everywhere, but if you can ask them, can you put a finger where most of your pain is at? And it's usually pretty close to that top of that PSIS, and they'll have tenderness with compression over it. And next slide. So these are the main provocative tests. So you have distraction, your thigh thrust, Faber, which is, I think, one of the best ones to do, especially I'll do Faber and then do Fadir right afterwards. So I'm checking both ways. Compression test and Gainsland's. All of these tests are putting compression and irritation and forces through that SI joint so that we can actually see if it causes and reproduces their pain. Next slide. Diagnostic algorithm. This is very straightforward. Get a good history, do a physical exam, positive Fortin finger. If you have at least 3 of those tests positive, then you're looking at a positive, most likely an SI joint pathology. Once we have that information gathered, then submitting to the insurance to actually get the approval for an SI joint diagnostic block. There are a lot of insurances that will not even approve the SI joint blocks unless you have done that physical exam, and they will kick it back immediately if that is not fully documented in your chart notes. Next slide. So what is the medically necessary diagnostic injection? So we're looking at least 75 to 80% improvement with the local anesthetic that is used during that injection. And so these are usually done under fluoroscopy. With looking at the SI joint, you have to do 2. So this is very similar to your lumbar medial branch blocks. Only having 1 positive test is not a positive test. You have to do at least 2 injections. Looking at different requirements for looking at the Silo TFX and our other devices for the SI joint stabilization. 1 injection typically does need to be only diagnostic without any steroid, and 1 injection with steroid. Those usually need to be at least 2 weeks in between. It's not clearly stated. You can also do 2 injections with just local anesthetic if you have a patient who does not want to have steroids or has negative effects from those steroids. Next slide. There's a lot of imaging. So when I'm working a patient up for this, typically what I'll do is I'll order an SI joint injection with steroid as long as the patient is okay with that. If it helps, but it doesn't last, I usually see my patients back around 10 to 14 days. If that first injection provided short-term improvement, but it wore off quickly, then I'll start talking about the surgical options. I will talk to them about the steps that are necessary because there's quite a few of them that we have to gather this information in order to move forward with the surgery. So one is that we need to have imaging of the pelvis. We need to have x-rays of the hips. We want to rule out any sort of major osteoarthritis or issues within the hip joint itself that could be a confounding factor for the SI joint pathology. We also need to have a lumbar CT or MRI, depending on what the patients can have. And then we need to have a CT scan or an MRI of the pelvis as well, looking at the SI joints. There's 2 parts for this. One is that we have to rule out any other causes for the SI joint pain, but it's also used for surgical planning. If we have a patient with a lot of arthritis or gapping in that joint, we want to know where to put that device that is going to be able to anchor and provide that patient the support that they need and the improvement in their function. Again, the x-rays may not show us a whole lot. And a lot of times what I'm seeing even on my radiology reports is that they'll say no sacroiliitis, which means that they don't feel like there's any sort of inflammatory issues. But then further in the notes, it'll say degenerative SI joint changes. So those are the keys to look through, is not just reading the reports, the top report about what the radiologist saw, but also reading into the body to see if they made any comments on SI joint arthritis. Next slide. So non-surgical management, what can we do for these patients? The standard treatment of medications using NSAIDs, Tylenol, time, ice, heat, physical therapy are all important to try. SI joint belts can be helpful. The SI joint injections are both diagnostic and maybe therapeutic. They could last days, weeks, months, or years. We just don't know. But if there's any improvement at all, then we at least have a confirmation that we're in the right area. Radiofrequency ablation is an option. However, most insurances no longer cover this. So this was, I think it was last year, we were doing radiofrequency and Medicare decided that this was no longer a valid treatment option. For our office, we also do offer PRP injections. And so that is something that's out of pocket for patients too, but it is an option that they could try if they wanted to. Moving on from those is you get into the surgery. And so you have an allograft SI joints fusion, and then you have the TFX, which is the transfixing system with those two set screws that stabilize into the ilium and the sacrum itself. Next slide. Medical necessity. So there's a whole list of LCD guidelines that your different LCD providers can get you. Talk to your area reps and get that information, because it does vary from LCD to LCD. So there's a lot of areas that have subtle differences. So make sure you talk with your reps in the area that you know what your area requires. There's the standard that most of these do require those, that you need to have at least 6 months of conservative treatment. You must have severe chronic pain, so using an ODI scale to document that. You have to have had the diagnostic exams to show that there's positive SI joint dysfunction going on. 3 out of 5 of those tests need to be positive. You must have 2 injections into the SI joint that have used fluoroscopy that have provided at least 75% improvement. Typically 1 can have steroid, 1 without steroid. You have to rule out any sort of generalized pain disorder. And then you also have to rule out the hip and the spine as being a potential option for where the pain is coming from. Best diagnosis codes is the sacroiliac dysfunction, or sacroiliac arthritis is the M53.3. Having that all combined together can move things forward with the insurance. Again, making sure in your notes, I talked a little bit about before with Brittney, with ordering Zip, I do not put in the name of the device because it gets complicated. I just put in that I'm moving forward with a right SI joint fusion. And then in my notes, when I put in the ordering, I put in the company name so that we know who to contact and have the reps there. Next slide. So what is the silo? The TFX system, this is minimally invasive procedure. The incisions are little, like about 2 centimeters, 2.5, very small. Procedure itself takes 20 to 30 minutes, so very quick. We do these under MAC for our patients as well. We try to avoid using general if we can for most of our procedures. It is titanium implant and it has a porous surface. And then there is the allograft that creates that bony fusion. What this device does is twofold. One is that when you insert it into the joint, it actually opens up that joint. And so that relieves that arthritic change and that arthritic pressure of the bone on bone. And then we stabilize it with those screws and then with the allograft that's injected. And then we can see with this procedure in particular that it's biomechanically stronger than the leading SI joint fusions. Next slide. So talk tracks, very similar to everything else that we've just talked about as well. So surgery is kind of an easier process to move forward with. We talk about that it's minimally invasive, the incision is small, they go home same day. We do have our patients wear at least some sort of bracing for the first couple weeks, just to remind them that they need to not be bending and lifting and twisting. A little bit sore from the procedure, but a lot of my patients, when they come back in, say, I can tell a difference right away because of that release of that bone on bone that happens in the arthritic change. Pre-op labs, it's determined by your facility, making sure you have cardiac clearance if you need it, blood thinners, And then with this too, the nice thing is that this is much safer. And so that the posterior approach coming through versus the lateral, we're avoiding where all those blood vessels are and where the nerves are at. So we have a much safer option with this as far as the traditional 3 screws that come all the way across that joint. Next slide. Guidelines, same thing, bleeding is minimal. We use staples to close, so we have them keep that area clean and dry. We do give them some post-operative pain medication. It's still an incision. Some people take it, some people don't. And then we have them not soak until those staples come out and everything's healed up. Again, assessing for, any sort of signs of infection. Limiting their lifting and twisting, and no more than about 15 pounds for the first month post-surgery. Next slide. So this is a case study that we have. This is a 60-year-old male. I think this is actually Brittney's case study here. So he had multiple different surgeries that were completed. It's definitely, has multiple layers of pain. So our patients are not easy. They have things that are wrong everywhere. So for him, he's had the decompression, he had the stimulator, he also had a fusion for his general health cardiac stent. So we have that to think about as far as he's on a blood thinner. Has tried multiple injections, the PT, the stimulator, oswestry was high, and also his NRS was high. Low back pain came down into the anterior thigh, L2-3, pain was worse with sitting and activity. He had adjacent segment degenerative changes, chronic post-surgical pain, and SI joint. He had the scar over the iliac crest, limited range of motion, had some left drop foot, had positive SI joint findings on exam, but no groin pain with internal or external rotation of the hip. Next slide. So the imaging that was done shows everything that was there from the previous surgery. You have that the hip x-rays showed some mild degenerative change, but nothing. SI joint was unremarkable. The CT scan demonstrated that the fusion was solid. There was no issues with that. So we're ruled out everything else. And that's a lot of what this is for the SI joint fusion, is you want to rule out everything else to get the insurance to cover this. Also, you don't want to do a fusion if it's not going to help the patient. So getting the blood thinner clearance, diagnosis code is at M53.3. And then Brittney went with that left SI joint fusion. Next slide. And so here's the x-ray. So he also had the right SI joint. 6 weeks post-op, his NRS was down to a 2 out of 10, and then 3 months was down to 1 out of 10. So extremely beneficial for him. Next slide. I think we're getting close to time. So this was one of my patients. So again, our patients are very complicated. So you can see from her 51-year-old, she was pretty healthy, but had lots of issues with her back. And so we had done injections for her for about 8 years. Her RFs worked well for her lateral pain. She still had the central back pain. When we were able to do Intercept for her, the central back pain was resolved. On top of that, she was also having SI joint dysfunction. She worked as a healthcare provider, lots of bending forward. She did home health, really irritated her with her work. And so we had also been doing SI joint injections over the last 5 years, and they usually lasted for like 3 to 4 months. So after we had done Intercept and everything else for her lumbar spine, she's like, yeah, this all feels great, but my SI joint still really hurts. It was only on the right side, so it was lower than the lumbar sacral region. Pain was increased with bending, twisting, standing, and walking. Her physical exam showed positive signs of SI joint dysfunction, had no groin pain with the internal external rotation of the hip. Next slide. So we did the imaging for her. I haven't seen her in follow-up. She was seeing one of my other colleagues, but she's a 3 out of 10 on her pain score right now. She's over 70 to 75% improved and very pleased with the results at this time. She's now starting PT and wants to work on getting stronger. Next slide. I think we're getting close, if I can tell from my time here. So maybe time to open the feedback for questions instead of going through the next few slides here.
We don't have any questions at the moment. I want to thank Devon and Brittney for sharing their immense knowledge with us. This has been fantastic, such a wonderful opportunity to learn from them, to hear about patient selection and understand the workup of these patients. We do want to, as Aurora, to provide you the best support out there in the space. So please contact your local representatives so that way we can engage with you guys, provide you resources, and really help your patients. So I want to thank everybody for having a great webinar, and have a great evening.
Thanks, everyone.
Good night.